Welcome back to the Health Policy Doc. In today's discussion, we are going to examine the Medicare for All proposal that is being advanced by many of the Democrat candidates for President of the United States. This is a healthcare reform idea that has not historically had a lot of support in the United States. But with the Democrat candidate for president likely to support this approach, I think it's important to dive into the details of the Medicare for All idea. The details, of course, are a little extra dry and might be a little wonkish to the casual listener. But to really assess what this type of proposal would mean, it is important to truly gain an appreciation for what will occur when a Medicare for All proposal is implemented. For example, imagine what the impact of eliminating every job at all health insurance companies throughout the United States would be. That will happen if either of the two Medicare for All bills that will be examined today are enacted into law. Any proposal that would eliminate every job in a profession would normally be dismissed immediately. But it's important to take the time to understand all the components of the Medicare for All plan, both the good and the bad, before making a decision. As part of that assessment, we can balance the positive and negative aspects and see if there is a net positive return on investment to the community from providing health coverage to everyone using the Medicare for All approach. The Medicare for All concept is the United States version of a single-payer system. The single-payer approach to healthcare relies on the federal government providing health insurance to everyone. Today, the federal government provides Medicare insurance to U.S. citizens age 65 and older. The federal government, partnering with the states, also provides Medicaid insurance primarily to low-income citizens. So the federal government is already providing insurance to many people in the United States. What the Medicare for All plan would do is add the 48% of the population currently covered by employer-based insurance plans, the 8% of the population that is uninsured, and other parts of the population receiving coverage from other programs, all moving into a government-operated plan. Today, we are going to look at the details of two bills for Medicare for All. One is a bill previously offered by Senator Bernie Sanders, and the other by Representative Pramila Jayapal. Both of the plans are designed to have the federal government provide comprehensive benefits for all U.S. residents. Each of the plans would finance the cost through taxes and would have no premiums. Senator Sanders' plan calls for limited cost sharing, while Representative Jayapal's plan would have no cost sharing. Each of the plans would replace all private insurance, Medicaid, Medicare, and children's insurance plans. Employers would no longer be involved in providing health insurance for their employees. Enrollment in the Medicare for All plan would be a lifetime enrollment. Newborns would be auto-enrolled at birth, and others upon establishment of U.S. residency. Benefits would be designed based on 13 categories under Senator Sanders' plan and 14 categories under Representative Jayapal's plan. Categories include traditional health insurance benefits along with community-based long-term services, dental, hearing, vision, comprehensive reproductive services, and transportation. The federal government will make national coverage determinations for experimental items, services, and drugs. States will have the option to provide additional benefits at the state's expense. Senator Sanders' plan would have no cost sharing, except for possibly prescription drugs and biologics, not to exceed $200 per year. Any cost sharing must encourage the use of generic drugs and cannot apply to preventive drugs and cannot be imposed on individuals with household income less than 200% of the federal poverty level. Representative Jayapal's plan would have no cost sharing. One of the questions that always comes up in any health reform conversation is whether people will be able to keep their provider. Under the Medicare for All plan, all state licensed and certified providers who meet applicable provider standards and file a participation agreement will be able to participate. So it appears that as long as your doctor wants to participate in the Medicare for All plan, then you should have the opportunity to keep your same doctor. A concept known as balance billing, where a provider's charges are not completely reimbursed by the health plan, that are then billed to the patient are not permitted under the Medicare for All plan. Senator Sanders' plan determines how providers are paid in the same manner that is used today for the Medicare program, where a fee schedule is established by the federal government. Representative Jayapal's Medicare for All plan establishes provider payments through a global budget process and negotiations. Hospital and facilities would be paid a quarterly lump sum to cover operating expenses under a global budget. The amount of payments would be determined by annual negotiation between institutions and regional offices, taking into account multiple factors, including historical expenditures, data on costs, changes in volume, as well as other factors. Physicians and clinicians will be paid fee-for-service based on a fee schedule established by the federal government. Prescription drug prices are negotiated annually under Senator Sanders' proposal. Representative Jayapal's proposal includes negotiation of drug prices with drug manufacturers based on several factors, including variables like the total revenue from global sales. The federal government will establish a global budget for all health expenditures, consisting of various components like operations, capital expenditures for rural and underserved areas, quality assessment activities, health professional education, administrative costs, innovation, and prevention public health activities. Reserves would also be funded for epidemics, pandemics, natural disasters, and other health emergencies. Medicare for All will replace the current Medicare Part A, B, and D components. During a transition period, deductibles will be eliminated from Parts A and B, and out-of-pocket thresholds for Part D. The Medicare for All proposals will not place any restrictions on the sale of health insurance for any non-covered benefits. So private health insurers will be prohibited from selling policies, and employers will be prohibited from providing benefits that duplicate Medicare for All covered benefits. I think that this is a critical feature to understand. Health insurance benefits covered by Medicare for All will not be allowed in a private insurance plan. But other healthcare services could be sold by an insurance plan. Perhaps this would be benefits not traditionally included in health insurance, like alternative treatments such as acupuncture or Eastern medicine approaches. Before the full implementation of Medicare for All, Medigap insurers will be prohibited from denying policies. For the first 5 years of the Medicare for All plan, 1% of the global budget will be set aside to offset the economic dislocation of workers in the private health insurance market. Medicare for All will replace Medicaid for most services and Medicaid coverage for institutional long-term services. Other benefits furnished by a state Medicaid program that are not covered by the Medicare for All plan can continue to be provided as long as the state maintains the maintenance of effort. In other words, as long as they continue to fund whatever those additional services are. So today we touched on some of the key features and changes that would occur if Medicare for All is implemented. Clearly, Medicare for All will fundamentally change healthcare in the United States. The idea that everyone in the United States should have health insurance should be a goal of all comprehensive healthcare reform efforts. Medicare for All will accomplish that, but will also have a large impact on the economy by eliminating the health insurance industry. The challenge for policymakers will be to mitigate the negative impact of transitioning the health insurance market over to the government. Will job training and new opportunities develop to help with the displaced workforce? With respect to healthcare delivery, will the government be forced to ration care to meet budget goals? Will long waits for certain tests and procedures negatively impact the positive attributes of the U.S. healthcare system? These and many other questions need to be answered before jumping into the Medicare for All world. Healthcare reform will be a central part of the 2020 U.S. presidential race. Let's hope the politicians engage the policymakers to join the discussion and truly assess the merits of Medicare for All. Part of that discussion will need to examine the potential return on investment that will be achieved from a program like Medicare for All. Thank you for listening today, and please join the Health Policy Doc next time as we examine another topic from the health policy world.